Hello, students. Topic of this lecture is central neuraxial blocks and local anesthetics. Let me just share the screen. And we're gonna go full screen now. All right, so my name is Aleksander Aszkiełowicz, and I am an anesthetist working in the Department of Anesthesiology and Intensive Therapy of Medical University of Gdańsk. And like I said, the topic of this lecture is central neuraxial blocks and local anesthetics. First of all, we start with the definition of regional anesthesia, because central neuraxial blocks are blocks that are type of regional anesthesia. So regional anesthesia is a controlled, temporary, and reversible interruption of conduction in the neural fibers by infiltration of local anesthetics. If we perform it in the vicinity of peripheral nerves or nerve plexuses, then we call it peripheral blockade or peripheral block. Whether if we do that within the spinal canal, we call it a central neuraxial block. We distinguish three types of central neuraxial blocks: spinal anesthesia, epidural anesthesia, and CSE, or combined spinal epidural anesthesia, which is basically a combination of spinal and epidural anesthesia. If we wanted to look at the technique of local anesthetic injection during central neuraxial blocks, we distinguish single shot blocks, we distinguish continuous blockade, and we distinguish mixed type of local anesthetic injection, which obviously includes both single shot and continuous infusion. So first, a brief history of spinal anesthesia. It all started in late 20th century when Walter Winter performed his first lumbar puncture. Then there was December 1890, when German physician Heinrich Quincke performed his first spinal block. But the father of spinal anesthesia is said to be August Beer, another German physician, who performed a first deliberate spinal anesthesia on 16th of August, 1898. If we wanted to look at the history of epidural anesthesia, there were four prominent characters, we can say. First one was James Corning. He was a neurologist that performed epidural injection to treat chronic pain in lower extremities. And then there was a duet of two physicians, Sicard and Caitlin, that used epidural injections to treat lumbar pain. And eventually there was a French physician, Jacques Forestier, that performed also epidural anesthesia for the purposes of surgery. Continuous epidural anesthesia. This technique was basically developed a little bit later than single shot epidural anesthesia, as you can see. Two names that you don't have to memorize absolutely. this Romanian physician Eugene Aburel and Spanish physician Manuel Corbello, and they both used a catheter that was placed inside epidural space to deliver continuous infusion of local anesthetics. And eventually, combined spinal epidural anesthesia. In the history of development of CSE, there is even a Polish Polish mark, we can say, physician Ryszard Rudziński that described this technique in 1923. In order to perform central neuraxial blocks, we need to be aware of the anatomy of vertebral column. Just to revise this, humans' vertebral column consists of 4 parts, we can say, 4 parts. Cervical part that consists of 7 vertebrae. Then the thoracic part that includes 12 vertebrae, lumbar part consisting of 5 vertebrae, and obviously sacrum and coccyx. What is really important while performing central neuraxial blocks is knowing how low does the spinal cord goes, because obviously you may know that we need to be aware of where the spinal cord is in order not to damage it during the central neuraxial block. So as you can see, the spinal cord goes differently low in different populations. As you can see, in Caucasian patients, usually it ends up in the vicinity of first lumbar vertebra. In African population, it may go a little bit lower than in Caucasian population. Usually it goes down to even a second lumbar vertebra. In pediatric population, both Caucasian and African, it goes even lower than in adult population. So even as low as 3rd or 4th lumbar vertebra. In order to perform central neuraxial blocks, we need to be aware of certain anatomical landmarks that help us to orientate on vertebral column. For instance, we can use the line that connects angles of scapula. Usually goes through the 7th thoracic vertebra. Obviously, lower edge of 12th rib goes, the line that connects lower edges of 12th ribs. It goes through the 12th thoracic vertebra. Iliac crest line that connects iliac crest is called Tufure line, and usually it goes through the 4th lumbar vertebra, whereas the line that connects superior posterior iliac spines goes through the 3rd sacral vertebra. So when we inject local anesthetic inside the spinal canal, Our goal, our aim is to anesthetize basically spinal roots, right? Spinal nerves, we can say. That obviously consists of dorsal roots that drives centripetal impulses, among others. Obviously, there are pain impulses driven by this root, and ventral root that drives centrifugal impulses, among others. Obviously, the impulses that allows us to control muscles. We mustn't forget that spinal nerves also connect with the autonomic nervous system. To be more precise, sympathetic nervous system. And the consequence of preganglionic sympathetic fibers blockade is obviously a vasodilation of area that is supplied by these nerves, and obviously it may lead to hypotension. The structure, the lines that allow us to orientate on the width of central neuraxial block are called dermatomes. They, like I said, they allow us to assess the block extent on the body, as you can see on the pictures here. Our body is divided with these dermatomes, and dermatome is an area of the skin with the sensory supply by a single spinal nerve. So basically, you can say it's a single spinal segment. If we wanted to put this knowledge into practice, if we perform central neuraxial block, no matter if it's a spinal or epidural, we can use dermatomes to help us orientate how wide the block is. For instance, if our block reaches the line that connects nipples, then we say that our block is reaching T4. If it reaches only down to around the area of xiphoid process, then we say it's T6. Umbilicus, T10. L1 is obviously a level of interpubic joint, and L3 is a top border of patella. The tool that allows us to assess the motor blockade that is obviously included in central neuraxial blocks is called a Bromwich score or Bromwich scale. How do we assess motor block with the scale? Obviously, simply we ask patient to flex the leg. If patient is able to fully flex his or her leg, including the hip joint, knee joint, and the ankle, then we say that the Bromwich score is 0. So basically the motor block is absent. If the patient is unable to flex the leg in hip joint, but still is able to flex his or her leg in knee joint and ankle joint, then the Bromwich score is 1. If patient is only able to flex ankles, then we say that the Bromwich score is 2. Whether when patient is completely unable to flex the lower extremity in neither of these joints, then we say that the Bromwich score is 3. So we also say that the mater block is full. There is this specific sequence that the block is developing, we can say. First, there is the diminish of the sense of temperature. After the loss of sense of temperature, there is a loss of pain sensation. After that, our patient is unable to sense touch, and eventually there is diminish of movement ability. This is obviously important from the clinical point of view, since the sympathetic block usually reaches the highest amounts of segments. Sensory block is a little bit less prominent, we can say. Usually it reaches 2 to 4 segments lower than sympathetic block. And motor block is usually the block that reaches even 2 segments lower than sensory block. So in order to sum it up, sympathetic block is usually the block that reaches the most amount of dermatomes, we can say, or the usually is the highest block, sympathetic block. Then sensory block is a little bit lower than sympathetic block, and the lowest one would be motor block. So how to perform spinal anesthesia? Spinal anesthesia is basically based on the deposition of local anesthetics between basically straight inside the cerebrospinal fluid. In order to do so, we need to puncture dura mater. We do that usually due to safety reasons below the spinal cord, obviously. So the safest space to do so would be around L3, L4. As we puncture the dura mater in that area, we introduce the needle until we sense the loss of the resistance. As we do so, we pull the mandrin, the stylet, out of the needle, and we should obtain the outflow of cerebrospinal fluid that confirms that the tip of the needle is inside the spinal, is inside the intrathecal area. So we punctured the dura mater. We can do that obviously in patient sitting, in sitting patient in upright position, or we sometimes can ask patient to lay on his or her side. So basically patient is in lateral decubitus position, and we can also perform spinal anesthesia in that position. So this picture basically shows what I just said on the previous slide. So we puncture dura mater. We get inside the intrathecal space, as you can see here on this picture. We obtain an outflow of cerebrospinal fluid. As we do so, we we connect syringe to the needle end. Through this, with this syringe, we inject local anesthetics inside the cerebrospinal fluid, inside the intrathecal space. And like I said before, we can do that in basically two ways, either in patients sitting upright, like you see on this pictures on the left side of the screen, or we can put the patient in lateral decubitus and do that on patients laying on their sides. Spinal needles differ with size, obviously, and these colored tips of these spinal needles basically tell us about the size of the needle. So as you can see, we have different sizes of the needle. This is basically what this table shows us. Mostly we use small, or I would say thin spinal needles, such as 27 gauge, 26 gauge, or 25 gauge spinal needles. But of course, we have other bigger, thicker spinal needles, as you can see, even all the way down to 18 gauge, which is the thickest spinal needle that we have. Spinal needles also differ with the type of the needle tip, with the type of the bevel, we can say. If we have needle that ends up with a sharp bevel, we can call it cutting edge also. We call it either Quincke needle or spinocan needle. And the other type of spinal needle is the one that ends up with the tip that looks somewhat of the tip of the pencil, and we call them pencil point needles. And among pencil point needles, the most popular ones would be Sprott needle or Whittaker needle. And these numbers that you see on the left side of this picture describe the frequency of post-dura puncture headaches. The risk of post-dura puncture headaches, depending on the type of the needle bevel. As you can see, sharp needles with the cutting edge, such as Quincke needle or spinocan, have way greater carry way greater risk of post-dura puncture headaches compared to pencil point needles, such as Sprott needle or Whittaker needle, that carry lower risk of post-dura puncture headaches. So, how do we prepare to perform spinal anesthesia? Obviously, we start with the preoperative preparation of our patient. We need to collect patient's history. We need to run some lab tests, such as morphology, such as coagulogram. We need obviously to fully explain how the procedure will look like. This explanation has to be detailed, and we need to obtain informed consent for central neuraxial block. doesn't matter if it's spinal anesthesia or epidural anesthesia, obviously, then we need or we may order some pre-medication in order to ease patients' anxiety. The block itself is being performed with careful preparation. And due to the risk of serious adverse events, drugs and equipment for general anesthesia must be readily available, no matter if we plan to add some general anesthesia to our central neuraxial block or not. There has to be a direct access to resuscitation set, obviously, an oxygen supply, and mechanical ventilation device. Before we perform central neuraxial block, we need to measure blood pressure and patient's heart rate. Then we position patient in a certain position, either it's a upright position or lateral decubitus. So we start with the identification of anatomical landmarks. And for the purposes of spinal anesthesia, we most often use the two-finger line, so the line that connects two iliac crests together. As you may remember from the previous slides, this line basically indicates the level of fourth lumbar vertebra. So we start with the careful palpation of patient's back. We try to identify lumbar crests, and we sort of like draw this imaginary line that connects these two crests, and then we go to the vertebral column. We carefully palpate the vertebral column at the level of the two-finger line, which basically indicates us the lumbar, the fourth lumbar vertebrae level. Obviously, our goal is to palpate the intravertebral space, so the space that lays between two vertebrae. We need to carefully disinfect the lumbar area of vertebral column, obviously, and the anesthetist has to be fully sterile while performing the spinal anesthesia. So anesthetists have to wear a cap, mask, obviously sterile gloves, and sterile gown is also recommended. We need to cover the puncture site with a sterile drape, obviously sterile draping, and we fill the syringes with solution of local anesthetic that we're going to use during our spinal block. So this is how it looks like in the operation room. So usually anesthetic nurse is helping us to put the patient in a desired position. Here you can see spinal anesthesia being performed in patient in upright position. The anesthetist usually sits behind patient's back after careful palpation of the anatomical landmarks of the vertebral column. The skin is being infiltrated with short-acting local anesthetics such as lidocaine. Then the introducer is being placed inside the intravertebral space, and through that introducer, the actual spinal needle is being introduced. all the way down till we sense this specific click that accompanies the puncture of dura mater. As we sense that click, we carefully withdraw the mandrin from the needle, and we should obtain the outflow of cerebrospinal fluid in order to perform a successful spinal anesthesia. So like I said, we start with infiltration of the skin with short-acting local anesthetic, such as lidocaine, like I said. Then we introduce the needle. Usually, before the needle is introduced, since we use very, very thin spinal needles, we most of the times we introduce this special introducer that is a little bit thicker than the needle itself, and it helps us to pass through the skin, the subcutaneous tissue, and most important, through the ligaments, supraspinal ligament, the intraspinal ligament, and the ligamentum flavum of the vertebral column. Through this introducer, we put the actual spinal needle, and after we penetrate dura mater, which is usually accompanied by this with the specific click that is sensible on the needle, we remove the mandrin and wait for the CSF, so cerebrospinal fluid, to appear in the needle. As cerebrospinal fluid appears inside our needle, we are ready to deposit local anesthetic, and we do so. We deposit local anesthetic with or without specific adjuvants or adjuncts, we can say. After the injection is over, we are ready to remove the spinal needle. We do so, and after that we remove sterile dressing and quickly position patient in a certain position, and that is required by a specific type of surgery. Most often, patient just lays on a back. So there are several factors that impact the extent of spinal block. We can say that affect the block spread. First of all, the most important factor that affects the spread of local anesthetic inside the intrathecal space is the baricity of the solution. Basically, baricity means somewhat of weight of the local anesthetic. By weight, we mean proper weight of the local anesthetic. We compare proper weight of local anesthetic to proper weight of cerebrospinal fluid. Obviously, other factors that affect the block spread is the position of a patient during and after the injection, the height of the injection site, obviously, the amount of injected local anesthetic, and by amount we mean both the volume and the concentration. Speed of the injection of local anesthetic also affects the block spread. The higher the speed, the higher the block spread. And the technique of the injection, there is the specific technique of the injection that is called barbotage. And this technique is basically about about injecting and withdrawing local anesthetic during the injection. Other factors that are, you may say, patient-dependent factors would be patient's age, patient's height and weight. And like I said before, the most important factor that affects the block spread would be the baricity of the local anesthetic solution. So baricity is somewhat of the relation between the proper weight of the local anesthetic compared to proper weight of cerebrospinal fluid. And among local anesthetics, we distinguish isobaric solutions that have their proper weight very similar to proper weight of cerebrospinal fluid. So as you can see on this picture above, if we inject isobaric solution at the level of L3, L4, most of the local anesthetic remains at the site of injection. Whereas if we use hyperbaric solution, so the solution that that has proper weight higher than the proper weight of cerebrospinal fluid, it behaves according to gravity inside the intrathecal space. So as you can see on the bottom picture, the local anesthetic basically spreads according to gravity and spinal canal natural curvatures inside the intrathecal space. So if we inject the same volume of hyperbaric solution at the level of L3, L4, most of this solution goes both into the caudal and into cranial direction of the intrathecal space. The use of hyperbaric solution allows us to extend the block spread, you may say. Other factors that affect the that was the slide we already spoke about. So you may wonder what type of drugs do we inject inside the intrathecal space. Obviously, mainly we inject local anesthetics such as bupivacaine, levobupivacaine. That would be only in the United States, since this drug is not registered in the European Union. Ropivacaine, lidocaine, or prilocaine. We have different concentrations of these drugs, as you can see in this table. This table also shows us the medium volumes of the drugs that are injected inside the intrathecal space, total dose of drug that is injected inside this space, the time of action of the block, the time of the duration of the block, you may say, and the elongation effect if we combine certain local anesthetic with vasoconstrictive agents such as norepinephrine or epinephrine. Like I said, there are also specific adjuvants that you may add to local anesthetics while performing spinal anesthesia. And the goal of that would be to prolong the effect of spinal anesthesia. Adding adjuvants also allows us to reduce the dose of local anesthetic that is being injected inside the intrathecal space. Usually it also allows us to improve the quality of anesthesia alongside with the reduction of splanchnic reflexes, for instance, during laparotomy, or reduction of incidence of shivering, nausea, and vomiting during surgery. But also adding adjuvants to local anesthetics while performing spinal anesthesia carries some side effects, such as pruritus, nausea and vomiting after surgery, or the risk of respiratory depression. Basically, these side effects apply to opioids as adjuvants to spinal anesthesia. So, like I said, most common adjuvants for the in spinal anesthesia, most frequently used adjuncts to local anesthetics would be opioids. And you can see that we have 3 opioids that we can inject inside the intrathecal space. One of them would be spinal morphine. The average dose that is being injected inside that inside the intrathecal space would be around 100 micrograms. Other opioid that might be used during spinal anesthesia would be sufentanil, and with the average dose of 10 micrograms, and fentanyl. The dose of fentanyl used in spinal anesthesia varies between 10 and 25 micrograms. You need to remember that if we use opioids as adjuncts to local anesthetics while performing spinal anesthesia, we need to monitor the patient in the post-operative period. And the thing we need to be really concerned about is the threat of respiratory depression. That is why we are obliged to monitor patients' saturation and number of breaths per minute. If we used fentanyl or sufentanil as an adjunct to local anesthetic, the necessary time of monitoring is 6 hours, whereas if we use spinal morphine, this time extends to 12 hours. Other adjuvants that we can use in spinal anesthesia would be drugs that affect NMDA receptors, such as ketamine or magnesium sulfate. We can use drugs that affect GABA receptors, such as midazolam or baclofen. Clonidine or dexmedetomidine would be the drug, the adjuncts that affect alpha-adrenergic receptor. And finally, we can use drugs that affect muscarinic receptor, and that would be neostigmine. You may wonder how risky spinal anesthesia is, and you may be surprised, but it's a pretty safe procedure. If we compare the amount of serious adverse events during spinal anesthesia and compare it with serious adverse events that happen during general anesthesia, we may say that these two types of anesthesia basically carry similar risk of serious adverse events. As you can see, paraplegia or serious neurological deficits happen pretty rare because paraplegia happens 5 every 550,000 spinals. So I would say it's pretty rare. Neurological deficits happen 7 spinals every 550,000. So I would say that the risk is comparable to serious adverse events risk during general anesthesia. Of course, serious adverse events happen pretty rarely, but there are some adverse events that happen pretty often after spinal anesthesia. And the adverse event that is basically included in, you may say, every spinal anesthesia would be hypotension, since, as you remember from the previous slides, we not only diminish sensory and motor innervation, but also we affect sympathetic nervous system, and that leads to vasodilation, and obviously a result of that would be hypotension. So hypotension is one of the most frequent adverse events after spinal anesthesia. Hypotension that is often combined with bradycardia. And in order to treat that adverse events, we use fluid therapy. We may inject patients with atropine, ephedrine, or we may simply put patients in Trendelenburg position. That helps us to ease this hypotension side effect. Bradycardia, even cardiac arrest due to bradycardia may happen during spinal anesthesia, and obviously to treat this serious adverse event, we would like to use atropine and epinephrine as it happens. Total spinal anesthesia is also a adverse event that may happen, not so often, I would say. What is a total spinal anesthesia? Basically, total spinal anesthesia is a overextension, I would say, of spinal block. So basically, if we perform spinal block that reaches all the way up to T2, we may accidentally affect the sympathetic nervous system that innervates heart. Sometimes the spread of the block is even higher than T2, rarely, thankfully, but it may happen. So it may even affect diaphragm. So we need to be aware of that as we perform spinal anesthesia. So basically, total spinal anesthesia would include a full sympathetic block that gives our patient severe hypotension. It includes diaphragm paresis, so our patient will become apnoic, obviously. And in order to treat that, we need to intubate patients, so endotracheal intubation is required. We need to introduce mechanical ventilation in order to treat this diaphragm paresis. And obviously, we need to start catecholamines infusion in order to fight this severe hypotension that is included in total spinal anesthesia. Obviously, first of all, we need to use sedative drugs, because if we wouldn't do so, our patient would be fully aware of everything that is going on. So this, I mean, maybe not fully aware, because this severe hypotension would probably lead to loss of consciousness, but eventually, but still, we need to use some sedatives in order to keep our patient asleep, as during the time of total spinal anesthesia, because that would be simply unethical to not to use sedatives during that. So other early adverse events of spinal anesthesia include nausea and vomiting, usually due to hypotension, and obviously thermoregulation disorders. You remember from the previous slides that we also block sympathetic nervous system. That leads to vasodilation, and obviously vasodilation leads to loss of temperature. So during regional anesthesia, during central neuraxial blocks, our patients may encounter some severe hypothermia. So the core temperature may drop even as low as 35 degrees Celsius, and that may affect the activity of some enzymes, some hormones inside our patient's body. So we need to be aware of that. We need to keep our patients warm as we perform, not only as we perform spinal anesthesias, but when we operate in patients that are spinally anesthetized. Late adverse events of spinal anesthesia that may develop several hours up to several days after spinal block would be urinary retention, and we treat that with parasympathicomimetics such as carbachol or neostigmine. Obviously, there is a necessity to catheterize patient's bladder since the patient is unable to urinate. Other late adverse events include back pain at the site of the injection, post-dura puncture headaches. So this PDPH abbreviation stands for post-dura puncture headaches, and neurological deficits. I would like to focus on post-dural puncture headaches since this is the late adverse events that may happen pretty often in patients anesthetized with spinal anesthesia. So what are the symptoms of post-dural puncture headaches? How to diagnose post-dural puncture headaches? First of all, the type of the headache. This is a orthostatic headache. That means that the pain exacerbates as patient arises from lying to standing or sitting position. The type of pain is this is basically a I would say vascular pain. Symptoms of this pain would be burning, blunt, pulsating headache that usually presence in the frontal or occipital region, and may often radiate to neck or arms. The intensity of pain varies from mild to really intensive. Coughing, sneezing, or performing Valsalva maneuver would exacerbate the pain. Post-dural puncture headache may be accompanied by lower back pain, also vertigo, tinnitus, some hearing disturbances, diplopia, blindness, photophobia, and nausea. It may start within a few hours or even up to a month after the spinal anesthesia, but most often it starts within 72 hours after spinal anesthesia. 90% of PDPHs start within 72 hours after spinal anesthesia. Rarely, it may even develop after 5 to 14 days after spinal anesthesia. What are the risk factors of the development of post-dural puncture headaches? And patient-related risk factor would include the age. As you can see, the younger the patient, the higher the risk. The sex of the patient. It is 2 to 3 times less often in males. I'm sorry, ladies. Low BMI patients would also be more prone to the development of post-dural puncture headaches. Patients that have positive history of PDPH events, the history of chronic headache, so mind patients with migraines, for instance, these patients would be also prone to develop PDPH after spinal. Other risk factors that are related to patient would be the height of the patient. So the taller the patient, the lower the risk. Low BP. If patient is hypotensive before spinal, the risk of PDPH is greater. Dehydration before the procedure also increases the risk of PDPH. Also, non-smoker patients would be in a risk group of post-dural puncture headaches. If we wanted to see non-patient related risk factors, that would be, first of all, the size of the needle. The thicker the needle, the higher the risk of the PDPH, and also the shape of the needle. So the shape of the bevel, we may say, also affects the risk of PDPH. Like we said at the beginning of this slides, there are 2 types of spinal needles: the ones with the sharp bevel, such as Quincke needles. They carry higher risk of PDPH comparing to pencil point needles, such as Sprott needles or Whittaker needles, that carry lower risk of PDPH. Also, the orientation of needle shaft. If we orient, if the needle shaft is facing towards the cranial direction, the risk of PDPH is higher. Angle of puncture of dura mater also affects this risk. Number of punctures of dura mater, obviously, the higher the number of punctures. So if we continuously try to perform spinal and we fail, and while do so we puncture dura mater several times, the risk of post-dura puncture headaches would be greater. the reinsertion of Mandarin as we finish the injection of local anesthetic decreases the risk of PDPH. Also, maybe the most important factor is the experience of the anesthetist. If the anesthetist is very experienced in performing spinal anesthesia, then the risk obviously is lower. But like I said, one of the most important, if not most important factor that affects the risk of PDPH would be first, the size of the needle. The thicker the needle, the greater the risk. And secondly, the shape of the bevel. So sharp needles, such as Quincke needle, carry higher risk of PDPH, whereas pencil point needles, such as Sprott needle, carry lower risk of PDPH. How do we treat post-dural puncture headaches? We have several ways of treating PDPH. Our goals in treatment of PDPH would be, first of all, since the PDPH itself is a result of excessive loss of cerebrospinal fluid through the hole in dura mater, we would like to, first of all, decrease the loss of CSF during the procedure itself and after the procedure. We would like to hopefully close the gap in dura mater, that the gap that is a result of dura mater puncture as we perform spinal. And of course, lastly, we would like to decrease the dilation of brain vessels, since this mechanism is also very important in the development of post-dural puncture headaches. So we have, like I said, few ways of treating PDPH. First of all, we have conservative ways of treatment, such as bed rest, but you need to remember that it's not a prophylactic method. So basically, we do not advise patients to have bed rest after being anesthetized with spinal anesthesia, because bed rest does not prevent the PDPH, but only it eases the symptoms of PDPH. There are also unconfirmed methods of unconfirmed effectiveness, such as abdominal bandage. The rehydration also does not have strong evidence-based medicine. Painkillers that we may use in order to ease headache would be paracetamol, NSAIDs, and antiemetics. More aggressive ways of treatment of PDPH include use of methyloxanthines, such as caffeine. We have special tablets special caffeine tablets. The drug is called Coffeecorn 40, and this drug consists of caffeine and ergotamine. As you can see, 100 milligrams of caffeine and 1 milligram of ergotamine. So as you can see, there is this specific regimen of use of this drug. As PDPH appear on the first day, we would like to give patient 1 tablet every 4 hours. On second day, 1 tablet every 6 hours. On the third day, 1 tablet every 8 hours, and finally on 4th day, 1 tablet every 12 hours, hopefully hoping that this treatment would ease PDPH. You can see that 1 shot of espresso contains from 50 to 100 milligrams of caffeine. So basically on a first day of treatment, we serve 1 shot of espresso every 4 hours to our patient. We may also use other methyloxanthines such as theophylline. The dose would be 5 milligram per kilo. Obviously, intravenous injection or infusion, I would say, of this drug. Then we give repetitive doses of 0.4 to 1 milligram per kilo every 12 hours. Other drug, that is synthetic adenocorticotropin. The drug is called Synecten. This drug basically increases the adrenal cortex stimulation. Basically, this affects with the increase of cerebrospinal fluid production. So the intensity of PDPH should be lowered if we use this drug in our patients. Aggressive treatment of PDPH may include use of gabapentin or pregabalin, oral gabapentin, oral pregabalin, oral sumatriptan, so the drug that is utilized in treatment of migraines, mitrazapine as well, the intravenous injections of hydrocortisone, basically the same as Synecten. It increases the production of cerebrospinal fluid. Eventually, we can use occipital nerve blocks, bilateral occipital nerve blocks, that would also help our PDPH patients. Eventually, we have, you may say, ultimate way of treating the PDPH, and that would be epidural blood patch. So basically, this way of treatment relies on mass effect, and our goal is to form a clot over the puncture in dura mater. In order to do so, we draw around 20 cc's of patient's peripheral blood, and with the TUI needle, we locate the epidural space and inject the blood inside the epidural space. Our goal is to aim a clot over the hole inside over the hole in dura mater. So basically, this is our goal. Like I said, formation of hematoma. But sometimes this way of treatment may carry some serious side effects, mostly neurological complications. As you can see, there are some reported cases of transient neurological symptoms. The myelitis, even subarachnoid abscess, cauda equina syndrome, meningitis, or even direct lesion of the spinal cord. So as you can see, this ultimate way of treatment of post-dura puncture headaches carries some risk of serious adverse effects. That would be all about spinal anesthesia. Next part of this lecture is epidural anesthesia, so the other type of central neuraxial block. What is epidural anesthesia? Basically, it's an injection of local anesthetic between the layers of dura mater. So simply we inject local anesthetic inside the epidural space. What epidural space contains? Basically, this space contains connective tissue, some fat tissue, some venous plexuses, arteries, lymphatic vessels, and of course, spinal nerve roots. As you can see on this slide, there are we need to be aware that I will tell you about that on next slides, the ways that we identify epidural space. But in order to and I would like to emphasize that the statistics tell that in 80 to 90% of patients, pressure in epidural space is negative. This negative pressure in epidural space is absent in pregnant women, and I'm telling about that because one of the most frequently used methods of identification of epidural space would be a loss of resistance method, and that method basically bases on the phenomenon of negative pressure inside the epidural space. So, as you can see, the epidural space has different width in different parts of the vertebral column. It's the widest in the lumbar area. In mid-thoracic area, it's a little bit narrower than lumbar, and eventually in cervical area, it's the narrowest. So in order to perform epidural block or epidural anesthesia, we use certain types of needles. Mostly we use TUI needles. So as you can see, this needle has this curved bevel, sharp bevel with the orifice facing one side of the needle. So how do we perform epidural block or epidural anesthesia? This anesthesia is obviously performed in sterile settings, such as like spinal anesthesia, because we basically manipulate in the area of spinal canal. So you may imagine that being unsterile and manipulating in that area carries a high risk of infectious complications. So first of all, we start with the infiltration of skin and subcutaneous tissue with short-acting local anesthetics, such as we did during spinal anesthesia. Most of the times it's just lidocaine, 1% lidocaine solution. Then we introduce as we anesthetize the intravertebral space with local anesthetics. We introduce the TUI needle, then we remove the mandrel and attach the special type of syringe that is called a loss of resistance syringe. this syringe allows us to sense as the pressure suddenly drops in the epidural space. So basically, we introduce the TUI needle down the vertebral column, you may say, as we do so, we continuously press the piston of the syringe. As we reach the epidural space, there is a sudden drop of pressure, so the piston is being easily inserted inside the syringe. Other way of identification of epidural space would be a hanging drop method, and you see that on these pictures here. So basically, as we insert the TUI needle between the intravertebral ligaments, we hang a drop of saline at the end of the TUI needle, and we simply introduce the needle down the patient's vertebral column. As we reach the epidural space, the pressure at the site of the needle becomes negative, and the drop is being withdrawn inside the needle. So basically, this method also is being used by some anesthetists. But like I said, most popular way of identification of epidural space would be the loss of resistance method, and we can use both air or saline to perform this identification of epidural space. Hanging drop method would be an alternative method to loss of resistance, like I said on a previous slide. And finally, we have some specific devices that allow us to detect the epidural space, such as EpiDrum or the EpiSure. But I would like to focus on the loss of resistance method, since this method is being used most of the times during performing the epidural anesthesia. So, like I said, we may use either air or saline inside the loss of resistance syringe. If we use air, then it's easier to recognize the dura puncture. If we use air, the local anesthetic that we inject after we identify the epidural space is not being diluted, obviously. Loss of resistance is, though, more difficult to recognize, and obviously there is a possibility of air embolism as we use air inside this loss of resistance syringe. If we use saline, the loss of resistance is easier to recognize. There is no risk of air embolism, obviously, but the dura puncture is somewhat more difficult to recognize, I would say. And obviously, if we use saline, especially high volumes, such as 10 cc's, we may accidentally dilute our local anesthetic that is being injected after we identify the epidural space. So we have two ways of performing the epidural anesthesia. We may either perform single shot epidural anesthesia, which is actually very rarely used anesthetic technique. Most of the times we perform continuous epidural anesthesia. And that type of anesthesia requires a catheter that is being placed through a TUI needle inside the epidural space. If we wanted to look at the types of anesthetics that we use in epidural anesthesia, basically these anesthetics are similar to local anesthetics that we use in spinal anesthesia. So lidocaine, prilocaine, bupivacaine, ropivacaine, or mepivacaine. But mind that the volumes of local anesthetics that we use in epidural anesthesia is way greater than the volumes that we use during spinal anesthesia. So, for instance, if we compare spinal anesthesia and epidural anesthesia with use of bupivacaine, you may remember from previous slides that the volume of 0.5% bupivacaine that was used in spinal anesthesia was 3 to 4 cc's, whereas the volume of bupivacaine that is used in epidural anesthesia is 15 to 30 milliliters, so 15 to 30 cc's. As you can see, it is way greater than, even 10 times greater than the volume that is used in spinal anesthesia. If we wanted to compare the onset of action of epidural anesthesia, and if we want to compare it with the onset of action of spinal anesthesia, then obviously it takes longer for the epidural anesthesia to actually kick in. So you see that it takes from 10 to even up to 30 minutes for the epidural anesthesia to fully kick in, whereas spinal anesthesia, usually it takes 3 to 5 minutes for the full development of block. Speaking about adjuvants in epidural anesthesia, obviously the adjuvants that we may use in epidurals would be, first of all, opioids. So morphine spinal, fentanyl, sufentanil, or alpha adrenergic receptor agonists such as clonidine. So the adverse effects of epidural anesthesia. We have immediate adverse effects of epidural anesthesia, or to be more precise, of local anesthetics that are used during epidural anesthesia. So first of all, toxic reactions due to overdose of local anesthetic or accidental intravascular injection of local anesthetic. Obviously, there are some signs of overdose. It may also be a result of similar symptoms may also be result of either anaphylactic reactions or a reaction to vessel constricting agent that was added to local anesthetic. So be aware of that, please. Early adverse effects of epidural anesthesia would include an accidental puncture of dura mater. This is the pretty common, I would say, adverse effect. I mean, like these adverse effects are rare generally, but if we wanted to speak about if adverse effect happens, then most often it would be a accidental puncture of dura mater, so followed by the injection of local anesthetic inside the intrathecal space that may end up in total spinal anesthesia, for instance, because of the differences in the injected volume, obviously, between the epidural and spinal. Sometimes subarachnoid injection of local anesthetic may also happen. It's pretty rare, but still it may lead to total spinal anesthesia. We may accidentally puncture a blood vessel inside the epidural space and inject a high volume of local anesthetic inside the vessel that goes in the epidural space, and that would also result in the local anesthetic that may also result in local anesthetic systemic toxicity. Accidental spinal cord puncture, really rare, but still it may happen. Extensive epidural blockade, pretty common, I would say, and the most common adverse effect of epidural anesthesia would be hypotension, such as the most common effect of spinal was hypotension. Same here. Epidural anesthesia also carries high risk of hypotension. Late adverse effects of epidural anesthesia would also be urinary retention, PDPH, if we accidentally puncture dura mater, some neurological complications such as epidural hematoma, such as cauda equina syndrome, meningitis, and abscess in epidural space, obviously. Anterior spinal artery syndrome, very serious yet rare adverse effect. If we add a vasoconstrictive agent to our local anesthetic, we unfortunately risk a vasoconstriction of anterior spinal artery, and that may lead to spinal cord ischemia, so be aware of that. And spinal nerve damage, obviously, is one of the late adverse effects or adverse events that may happen in patients anesthetized with epidural. If we wanted to compare spinal with epidural, because some students confuse it, not only students, some doctors even, some practitioners confuse these two types of anesthesia, since they are both performed on patients' back. They look somewhat the same, so some clinicians confuse these two types of anesthesia, spinal with epidural, if we wanted to compare these two types of anesthesia. So basically, puncture area. We may perform epidural anesthesia on every level of vertebral column, starting from the cervical area all the way down to sacral area. In all of these areas, we may perform epidural anesthesia. We may insert epidural catheter, theoretically, because practically we do that mostly in lumbar or thoracic part of vertebral column. But still, theoretically, we could do that even in cervical or sacral part of vertebral column. That is possible. So, on the other hand, spinal performed only in lumbar area. You need to remember that we cannot perform spinal higher than the level of L2 because we threat the puncture of spinal cord in that case. So you need to remember spinal, basically only lumbar area, L2, L3, L4, L5, and that's it. Whereas epidural, theoretically, on every part of the vertebral column, but most commonly thoracic and lumbar part of vertebral column, sorry. If we compare difficulty, spinal, very easy to perform. Epidural, it takes some skill. The difficulty is basically a result of the indication method. In spinal, we basically, you may say, blindly pierce the dura mater, and that's it. Whereas in epidural, we need to kind of like use this loss of resistance syringe and carefully advance this TUI needle because of its thickness and because of the fact that it has sharp bevel. We don't want to pierce the dura mater accidentally with this needle. Otherwise, our patient will get post-dura puncture headaches for sure. The deposition of local anesthetic obviously differs in these two types of anesthesia. Since in spinal anesthesia, we inject local anesthetic directly inside the cerebrospinal fluid. So we may say that we inject it inside the intrathecal space or subarachnoid space if we want it to be anatomically correct. Whereas in epidural anesthesia, we inject local anesthetic inside the epidural space, as the name says itself. The amount of local anesthetic that is being injected is way greater in epidural anesthesia than in spinal anesthesia. Like I told you, it's in epidural anesthesia, it's even up to 10 times higher. The volume is even up to 10 times higher than the volume that is injected during spinal anesthesia. The onset of action of epidural is slow, whereas the onset of action of spinal is really fast. In spinal, it's 3 to 5 minutes, whereas in epidural, it takes 10 to even up to 30 minutes for the block to kick in. Time of action in epidural, usually it's long because you remember that in epidural anesthesia, most of the times we utilize catheter that we place inside the epidural space. So we may continuously deliver local anesthetics through this catheter and extend the duration of the block. Whereas spinal, usually it's like 4 to 6 hours. Spread of local anesthetic inside the epidural space is less controllable. We have better control over the spread of local anesthetic inside the intrathecal space. Like we said, the boricity is the factor that affects the spread of local anesthetic inside the intrathecal space. The quality of the block, it's really hard to compare the quality of the block because these two types of anesthesia are kind of used to different sorts. The purpose of use of these two types of anesthesias are different. So it's really hard to compare the quality of the block. But if we wanted to compare I would say, strength of the block, then we say that in spinal, the block is really strong. So we may operate on patient that is being anesthetized with spinal, whereas epidural is it's really hard to achieve a anesthetic effect in epidural anesthesia. Most of the times we achieve analgesic effect. So basically it helps us ease intraoperative and postoperative pain, but we cannot operate on patients that are anesthetized only with epidural because the strength of the block is too low. Motor block, usually in epidural anesthesia, is absent, whereas in spinal anesthesia, usually it is present, well noticeable. Toxic reactions in epidural anesthesia are way more often since the volume of local anesthetics that we use during this anesthesia is way greater than the volumes that we use during spinal. So no wonder toxic reactions are more often. during epidural anesthesia. And finally, PDPH, so post-dural puncture headaches present in spinal anesthesia and absent in epidural anesthesia. Unless we puncture dura mater, then they are present. Okay, so what would be the indications for central neuraxial blocks? So first of all, surgeries in epigastric area, C-sections. Usually we need to achieve anesthesia that is up to T4, T6. In order to operate on the minor pelvis, so gynops, usually the level of T6, T8 is enough to operate in that area. Kidney surgery, T8. Bladder surgery, T10. Transurethra prostate resection or hip surgery, usually T10. Lower extremity surgery, such as hip joint replacement surgery, usually T12. Tight surgery, L1. Knee foot surgery, L2, L3. And surgeries in a perineum, the level of S1. Continuous epidural anesthesia may be used for as a analgesia of labor, as a analgesia in post-operative period or intraoperative period and post-operative period, as a analgesia after trauma, or as a long-term analgesia, or even as a long-term analgesia in oncological patients. So as you can see, what I said on the previous slide, if we compare the strength of the block between spinal and epidural, spinal has the spinal block is really strong. It allows us to operate on patients, whereas epidural block is used more as a analgesic method, both intraoperative analgesia combined with general anesthesia, obviously, and post-op analgesia. What would be the contraindications for central neuraxial blocks? Obviously, the lack of patients' consent, so basically patient's refusal. Some skin infection in planned site of puncture. Patients in hypovolemic shock because of the fact of blood pressure, of low blood pressure. We don't want to make it even lower as we perform central neuraxial blocks. A anticoagulant treatment. Patients that are treated with anticoagulants, we would have to strongly reconsider the pros and cons or benefits of performing central neuraxial blocks in these patients, since we risk a bleeding complications in these patients, and these bleeding complications may result in a formation of hematoma, for instance, in the epidural space, or subarachnoid hemorrhage, for instance, and that would have a serious neurological consequences. So in these patients, so patients that are treated with anticoagulants, we have to strongly reconsider central neuraxial blocks, since the risk of bleeding complications is greater in these patients. Patients with central nervous system disease, for instance, patients with paraplegia, would be bad candidates for central neuraxial blocks. So these patients also require some reconsidering of the benefits of central neuraxial blocks. And of course, lack of patient's cooperation. If patient doesn't want to or does not cooperate with the anesthetic nurse, with the anesthetists, as the central neuraxial block is being performed. For instance, patient is patient is anxious, patient is in pain, patient is not able to hold the position as we perform central neuraxial block. These patients would also be poor candidates for central neuraxial blocks. So what I want to say is, as we perform central neuraxial blocks, we need a full cooperation from the patient, since the procedure is very maybe not very risky, but if patient is not cooperating, if patient moves accidentally, then we may it may result in a serious complications. So we don't want to perform these blocks in patients that do not cooperate with us during anesthesia. So pros and cons of spinal. Pros: spinal is easy to perform, like I said, very effective, with the effectiveness of over 90% of anesthesias. It gives us perfect quality anesthesia. It has immediate onset, and it takes low dose of local anesthetic in order to perform this block. Among cons of spinal anesthesia, we distinguish hypotension and bradycardia. Hypotension is basically a con of both spinal and epidural, but hypotension, bradycardia, some limited time of action. Usually this block is limited to 4 to 6, maybe 8 hours. Risk of PDPH is obvious con of spinal anesthesia. Epidural anesthesia, pros and cons. Pros of epidural would be a possibility of extending the time of blockade. If we insert the catheter inside the epidural space, we may continue the epidural block for 2-3 days after the surgery and use it as a very effective type of analgesia, of post-op analgesia. Like the second it has a little bit slower effect on hemodynamics comparing to spinal anesthesia. So basically, it gives us hypotension. It may give us bradycardia, but the onset of hypotension is slower than in spinal. And then finally, among pros of epidural anesthesia would be the fact that we do not puncture dura mater, so we don't risk PDPH. Among cons, epidural anesthesia is way hard to perform comparing to spinal. It has established effectiveness of estimated effectiveness of 80%, so a little bit less effective than spinal. It has slow onset. It takes even up to 30 minutes for the block to fully kick in. It has the strength of anesthesia is a little bit worse, and it carries a risk of toxic reactions. And finally, third type of central neuraxial block, so basically combined spinal epidural. The name says it's all. It's a combination of two of these methods, so spinal combined with epidural. We do that We have two different techniques of performing CSE. So this combined spinal epidural anesthesia. We can either use a single segment technique or double segment technique. And we can use needle through needle technique or needle beside needle technique. So here you see a single site technique, needle through needle. So basically we use TUI needle to identify epidural space, and through the TUI needle we place spinal needle, and we puncture dura mater with spinal needle that is placed through the TUI needle. Obviously, we cannot perform CSE high in the vertebral column. Usually, CSE is being performed up to L1, L2, since obviously, if we performed it higher, then we would threat a accidental spinal cord puncture during this spinal part of CSE, right? So different types of needles that are used to perform CSE. The most common type is the TUI needle that has an extra orifice that is dedicated for spinal needles. So as you can see on this lower picture, basically spinal needle that is introduced through the TUI needle goes from the other orifice, goes out from the other orifice. So, and this picture here shows us the single site technique, needle beside needle. So basically, first we identify epidural space with TUI needle, and we insert spinal needle aside TUI needle, just a little bit lower than TUI needle, as you can see on this picture here. This technique is less commonly used, at least in our clinic. We can even utilize ultrasound to assist neuraxial blocks. Here you can see a picture showing the ultrasound guided neuraxial anesthesia, sacral anesthesia, with use of ultrasound. Okay, and the last part of this long lecture would be local anesthetics. We divide local anesthetics into two groups, esters and amides. Among esters, we have cocaine, procaine. Usually esters are short-acting local anesthetics. They are being metabolized by plasma cholinesterases. So the phenomenon of hydroxylation is the one responsible for metabolism of ester local anesthetics. Use of ester local anesthetics is frequently accompanied with anaphylactic symptoms, and they rarely cause toxic symptoms, whereas amides such as lidocaine, bupivacaine, ropivacaine, so the most commonly used local anesthetics in central neuraxial blocks, they are metabolized in liver. Hydrolysis of the amide group. They give frequent toxic effects, but they rarely cause anaphylactic symptoms. So this is the chemical construction of local anesthetics, despite the group of local anesthetics, they are always built with the lipophilic aromatic group and hydrophilic amine group, and they only differ with types of substitute. Clinical manifestation of local anesthetic systemic toxicity is basically very important thing. So as we perform central neuraxial blocks, we need to be aware of what may happen to patients that we anesthetize with these blocks, and we need to be able to recognize symptoms of LAST, so local anesthetic systemic toxicity. Symptoms of local anesthetic systemic toxicity include neurotoxicity and cardiotoxicity. Classically, the symptoms start with the neurotoxicity, so basically an arousal of central nervous system. Patient starts to be awkwardly anxious. Patient may report some tingling, some paresthesia of tongue, lips, some headaches, tinnitus, metallic taste in mouth. Then becomes the depression of central nervous system. Patient may even fall in coma, and eventually it may end up with respiratory arrest. And cardiovascular system depression, cardiovascular toxicity includes the first rise of blood pressure, tachycardia, some arrhythmias, and it may even end up with cardiac arrest. So in order to prevent local anesthetic systemic toxicity, we need to use the smallest dose possible, inject slowly and aspirate frequently. We need to use vascular constricting agents to reduce absorption of local anesthetics. And this table shows us maximum doses of local anesthetics. We mustn't exceed these doses. What to do as the local anesthetic systemic toxicity happens? We need to treat it with a bolus emulsion of lipids, so 1.5 milliliters per kilo, and then followed by continuous infusion of 15 milliliters per kilo. Thank you for your attention.